So hi, welcome to Bottom Line Advocator podcast. We have got Dr. Joe Feurstein back with me today. We're going to talk about COVID and the latest on COVID. We have about a half hour with him in the middle of his crazy schedule. So let me just remind you, we do have a growing number of videos in our library on Facebook, also on our YouTube site. Bottom Line Inc. is the YouTube channel. So go there, share them. We've got some with Joe. We've got some with all sorts of other experts about COVID and about all sorts of other ways for you to stay healthy and strong and powerful in this crazy, crazy world. So let me welcome Dr. Joseph Feurstein. He is an amazing guy. He's the associate professor. I have to read his bullet points, so I'm always sure that I get all the details. I want to get it all right. He's the associate professor of clinical medicine at Columbia University in New York, and he's the director of integrative medicine at Stamford Hospital in Connecticut, which was kind of one of the ground zeros for COVID in this country. He was actively involved, buried up to his eyeballs in the ICU, helping people out during that very early time. He is a COVID-19 patient. He was a patient. He is a survivor.
I'm a winner.
Huh?
I'm a winner.
You are a winner. And in fact, you took hydroxychloroquine, which we're not going to discuss today, but you did live to tell the tale.
I took both of them.
Yes, and right. So you'd love to tell the tale. So another day, when anyone's got questions, let me just tell anyone, usually I invite questions during this, but because we only have a little bit of time with Joe, I'm going to ask you, put questions up there, and then Joe and I will answer them later on after the fact. If you have questions about the numbers, about the treatments, about the risk factors, we're going to go quickly through it all, but put some questions up into the chat and we will answer them after the fact. All right, my friend, it's so great to see you.
To you too. Always a pleasure, Sarah. Always a pleasure.
And let's see, State of the Union, all right, because the numbers were going down, then we have all these second spikes and it's been waving across the country. So give me kind of the State of the Union as the headlines will not let any of us have peace and the schools have started to reopen.
So worldwide, we're approximately 28 million cases and getting close to 1 million deaths. We're 908,000 deaths. This is as of today. USA, which obviously was the one of the big epicenters, we're still number one, and not for what we want to be, but we're number one right now at 6.3, almost 6.4 million cases, and we're at about 191,000 deaths. Now, Connecticut's doing rather well. There was a little bit of a spike in the last couple of days. Our percentage for a while in terms of testing was less than 1%, but I understand that in the last couple of days, we're up to 1.5%. To remind everybody, a red state, a red alert, which is bad, is where we test people and 5% of the people, of all the people we test with the nasal swab, not the blood test, the nasal test or the saliva test, but if it's over than 5%, that's high. And that means that every 20 people we test, one of them has corona. That's going to be a high. And that would, I'm sure, make the governor start to clamp down more. But we're still very low. We're 1% and just, I think we spiked a little to 1.5.
Well, I was just looking at the national stats and the curve. So I'll draw a picture. So the curve we grew up, we went up in April, right? And then it came down, and then there was this other little spike. But nationally, it's going down again. That's cases, right? So there was the talk about these increased cases in the Midwest. We went, the Northeast got it first.
Yeah.
And then it went to Texas, California, Arizona, Florida.
And now it's in the Midwest.
And those are all now going down. And then it popped up in North Dakota, and it popped up in Indiana, and some of those things. So, but I'm looking at the stats on North Dakota today. How to lie with statistics, right? So it's got the graph. The top bar is 6 people. And it's going up like this, right?
Right.
So we need to understand what those numbers are. Now, in the midst of that graph that shows that this case rate is going down nationally, the death rate is, here's a funny pun, it's flatlining.
Yes, exactly.
The death rate has not gone up at the same time.
That's
thinking about the original premise is, when are we going? Is the goal get rid of this germ, or how to manage it better, and how to flatten that curve so that the healthcare system can handle it. So put those numbers in perspective, because again, every day we're hearing headlines, the schools are opening up, there's cases that are up, which of course is going to happen. You had a video about a study where school children, if they stayed home, the cases were down.
Yes.
Of course, if we all stay in caves, nobody will ever get anything.
That's right.
So we need, help me with perspective on that, please.
So, I mean, what I'm going to say is that generally we have a I think this is rather good news. We have a much better protocol as to what works and what doesn't work. So I'll be very honest, when we first started seeing COVID, and we were the Northeast, and Stamford was an epicenter because it's so close to New York, right. And I was seeing it in Stamford and in Greenwich as well, working in the intensive care unit and in the emergency room. In the beginning, honestly, we were throwing everything and there was no, honestly, depending upon which doctor you were working with, it was their recommendations. Now we have standardization. So we know what to do. We know what works. When you come in to the hospital, if you are hospitalized, which means that your oxygen level is low, which means you need to get supplemental oxygen, and you're in worst case, if you have mild disease, you should definitely go home. If you don't have mild disease and you're in bad shape, then you go on remdesivir and you go on dexamethasone, because we have studies. We know it reduces duration of disease. We know it helps with mortality. So that's kind of where we go. Those are what we use. And there's...
Joe, you froze. Joe?
Also can use that again.
No, repeat yourself because you froze for a minute. I'm sorry.
Yeah, so...
We know we had mortality when dexamethasone and remdesivir was reducing
mortality and duration of time in the ICU. So basically, everybody gets remdesivir, everybody gets dexamethasone. That's it. That's what you can come in and you can order it, because that's what you're going to get. Mm-hmm. And then depending upon where you other things, you'll if you qualify, it depends on other comorbid conditions. You may get tocilizumab, which is another medicine that we were using. And then the plasma story is a little bit more complicated because we don't have total clarity on this. Obviously, there's a large, massive study that showed a improvement, a reduction in mortality. It was not 35% absolute reduction. It was a 35% relative reduction. What that means is that if you go from 4 to 2, the absolute reduction is 2%. You had 4%, now you have 2%. 4 minus 2 is 2. The relative reduction of going from 4 to 2 is a 50% drop.
Right.
So basically that was misspoken by the FDA, but the bottom line is that it's interesting, but it's not a randomized controlled trial.
Why is that? That's the way they report things all the time. I have to challenge that. They are always reporting the improvement on a percentage basis. If it used to help somebody 50% and now it helps them 70%, they'll say that that's a 40% improvement.
There's no question. The drug companies do this all the time. I think that is not very, I think that I always have a problem with that when drug companies report it. And it's nothing to do with COVID, just to do with generally drug companies are trying to show a 25% improvement. And then you look at the numbers and it went from 4 to 3. So you're saving an extra life and you're like, okay, fine. So I always find relative reductions, I think that they're a little cheap to me. And I say this to every drug rep when I see them.
It depends on what your scale is as well.
Right, but the bottom line is that I'm actually interested in the number. Yes. So if it goes down, the actual number of people. So in other words, there's a statistical thing called the number needed to treat. How many people you need to treat to get that improvement? And if that's a big number, that's not good. And if it's a little number, meaning you only need to do 7 people and you're going to save one of them, we're all over that. That's more useful information. I mean, I think that...
Oh, I got that. But in this case, everyone was freaking because we had a lot of people that we needed to treat and a lot of people that were potentially dying. So
yes, no, and the mortality rate, I think we are better at treating it and we are understanding what's going on and we have protocols, but there's no question about the fact that the curve has gone down, not because of the way we're treating it. I don't think that's true. The curve has gone down because of public health.
Well, but it's also, I mean, these rolling waves have occurred. They're not necessarily because of demonstrations. They're not necessarily because of political rallies. They're not necessarily because of parties at the bars. Yes, that helps, but these other waves that have shown up as it rolled to these other places,
so
it hasn't directly been tied.
Right, so, but I mean, look, the point is, it's hard to do that because you're looking for large events. So, for example, there was a big biking
South Dakota.
thing up in South Dakota, and I read a study based on telephones
Right.
that they think that spread 200 to 250,000 people. I don't know whether that's valid, but I read a study on how they think that worked.
They would have seen that. 250,000 people, they would have seen the spikes go
right,
all across.
so what I'm saying is this. Look, I'm actually less interested in the big stories of, yes, a whole load of people didn't wear masks when they went here or they went there. I'm more interested in, are you wearing a mask? Are you socially distancing? Are you being sensible? And it's really at the personal and the community level than anything else, because that's actually how this works. So yes, of course, you might get a spike if 10,000 people march here or march there, and how many of them are wearing masks? I mean, masks, honestly, are going to do much more than anything else. Masks, social distancing, washing your hands, and being sensible. I mean, much more than anything else. That's why it went down, because we were sensible.
So we've been sensible, although, again, different parts of the country are opening up. But again, to me, the case is it's a reflection of how much testing is going on. There's so many factors that are into it. And that death rate to me is critical. And then also, it's hard to find the numbers on hospitalizations, but my understanding is that hospitalizations are also down. So while case numbers may be up, and again, trying to give perspective, because I've seen some universities opened and then of course they spiked and they sent everybody home. Yes. Versus I had spoken to, I think it was David Katz a couple months ago, where he talked about, he'd written something about, should we have left the schools open originally? Left kids in the universities, let it go through the school, and they were in an isolated universe. So
that's an intriguing idea. I mean, the bottom line is that the young people, obviously the concern is that they are the spreaders, young people and kids as well, who are not particularly at risk. And it's really about, it really isn't about them at all, in the sense that what it's about is who they're going to go and see. That's what it's really about. And I think the people at most at risk, certainly in Connecticut, are now doing, did a better job of not getting exposed. And I'll tell you how I know this, because when we do antibody testing, unlike New York, where 20% of New Yorkers that they did a sample of have antibodies, meaning they were exposed to corona, our rates here are not more than about 10%. So I rarely have a patient who actually was exposed. And why? Because everybody was sensible. They stayed at home, they let it go. And if you're at higher risk, it's what you need to do. And now—
let me ask you this though. Yeah. So now our antibodies there are fewer people that have been exposed. The minute you let people back out, there's going to be more exposure. Cases are going to go up. People are going to freak. They're going to want to lock everybody in again.
So that's the reason why, obviously, it's about opening slowly, which is what the governor's trying to do. And then the other thing is that it depends on how you're behaving in terms of, look, if we just all decide, something, it's business as usual, forget about social distancing, everybody doesn't wear a mask and that's it, you better believe we're going to have a real problem. If we do this correctly, which is what people are trying to do now, and if you see something that's clearly a high-risk behavior, then but as long as we do the rest of it, I think actually what we're expecting, and this isn't just me, this is also the medical centers at Yale, the Yale system has this as their estimation. They think that what will happen is there'll be a baseline COVID amount of people getting COVID, it'll be swimming around a little bit, but we're not going to see a massive spike. Right. They estimate that in one of the hospitals, instead of having 120 or 130 people hospitalized at one time, they'll have a COVID unit of 30 or 40. So you can see it's a quarter of—
We'll get through it. So let me ask you this. I have a theory. I have a question about a theory. Yeah. You know how you need to exercise your body.
Yeah.
And you need to exercise your immune system in some ways, right?
Right.
So as the country has been in quarantine and in isolation and not exercising their exposure to all sorts of stuff, not just to COVID, but to anthraxes in our world, to chickenpox, to all the things that are running around, have people's immune systems now almost kind of depleted a little bit? And is there a risk as they open up? They're worried about the flu season now. Are people in some ways going to be at a higher risk of getting anything because they've been home?
So there's a very interesting concept, and it's a theory that's been brought up. And the answer is yes, I think that that's true, but I think it's true for a different reason. A lot of people that I see have put on weight during COVID because they weren't active. Mm-hmm. And obviously, exercise is important for normal human health, but they also put on weight. Now, the question is, patients who put on weight, patients who are obese, what happens when they get vaccinated? And the answer to the question is that there were some studies. One of them was done on hepatitis B, and it was done in Chapel Hill in North Carolina. And it was a case report about an obese lady who got a hepatitis B series. That's a bloodborne viral infection that affects your liver. And every healthcare worker is given a series of 3 vaccinations. Right. And once you get the 3 vaccinations, you should be good for years. She was good for exactly 11 months, and then she no longer had the vaccine. She never had immunity, and she lost it. And so the same thing is that they found that flu, if you were obese, your risk of getting the flu, even if you were vaccinated, was still 2 times as high as non-obese people, as people who are normal weight. The answer is that we think there's a thing called immunometabolism. In other words, the obese population have an underlying inflammatory state in their body, inflammation, and that is probably affecting negatively their immune system. And so it will not surprise me that that will impact on, now people have put on weight, this is their moment to get off our weight, because we know the risk factors for COVID were obesity, diabetes, hypertension, age, and unfortunately being in minorities. So this is not your moment to have uncontrolled diabetes. This is your moment to try and get your diabetes under control, because your life is going to depend on that.
So 2 questions. One is real quick. Minorities, I think that the connection with, there was a higher incidence among Blacks and Hispanics, but part of that, didn't that ring back to diabetes and other health issues?
So definitely
of those
ethnic minorities, absolutely. They have.
So it wasn't a race thing per se. It just was the physicality of the high incidence of physicality within.
Well, you also have to ask yourself a more general question, which is why, in general, is there a high percentage of hypertension in Haitians or Hispanic? And that's a bigger thing.
That's a huge conversation.
Right, that we're not going to get to. But yes, those were risk factors.
I just want to clarify that it wasn't a racial issue. It was
who should we vaccinate? Like when we get this vaccine, if it works and doesn't cause any problems, who should we vaccinate? And the answer is, it's those people. It's those people first. It's not my kid. It's not my 18-year-old kid. No, he can wait. High-risk people, the people who are going to have a bad outcome if they get corona.
I want to go to the vaccine in a minute. Let's stick on the weight gain for a second. I want to talk about prevention for a second and other risk factors. Obese is these people that morbidly obese, although obese technically is not as big as you think. We're not talking about my 500-pound life. And most people, they talk about the COVID-19, right? So they've gained, I'll call it 5 to 15 pounds or so.
So your BMI is going to go from one entire category. So the BMI is the body mass index, and anything between 20 and 25 is normal, and anything over 25 to 30 is overweight, and above 30 is obese. If you change 15 or 20 pounds, depending upon your actual body weight, but most people, you can get yourself nearly into a new category. So we need to get those 15 pounds off, which means you need to be moving again. We need to be working on focusing on nutrition. There's no question. Everyone's wearing masks. My gym is open, and my gym has you exercise in a mask. By the way, that's a big challenge. If you want to really work out hard, just exercise in a mask. It really is hard.
You need a bicycle in your basement, my friend.
Exactly right. No, and that's it. But when you wear a mask, you're like, okay, wait a second. Wow, I'm really going for it. And that's okay. That's okay. It should be hard.
Well, and I know also, even though, I mean, they talk about reduction in diabetes symptoms, blood sugar and blood pressure, even if you lose 10 pounds, it can make a big difference. So
we see that clinically all the time.
Right, so it goes both ways, right?
I say to patients, I can get your sugars down by hundreds of points in a number of weeks. You're not going to use 50 pounds. You don't need to. You do need to, but you don't need to do that for that to happen. It drops very quickly. Right.
So this extra weight, even if it's not 50 pounds, but if it's some, it's an increased risk factor potentially.
It's really not something you want to be carrying, and it's all part of the healthy person. How you go into Corona, I said this last time, is how you come out. If you're in good shape, you have a better odds. If you started off not in good shape, then it could go badly for you. Although we have a better plan now.
So there's another interesting risk factor. You did a little video about this, and I've read about it. We've reported on it as well. Is proton pump inhibitors.
That's right.
Acid suppressing medications, not like, taking Tums, but
no,
proton pump inhibitors.
So basically, American Journal
significant increase in risk.
Yeah, so basically Cedars-Sinai, American Journal of Gastroenterology, 53,000 people in LA, and they do a telephone and they ask you how many of them have COVID, and they ask them how many of them are taking the proton pump inhibitors. And
those include, give me some of the brands.
Prevacid, Protonix, Nexium, Prilosec, they work on reducing acid.
The ones that have the commercials that say, take one pill a day and you'll be able to eat your meatballs.
And it'll all be great. And their risk of contracting COVID was tripled.
Huge, right. Well, and those things are terribly dangerous anyway. Increased risk of pneumonia, hip fractures, jaw necrosis, all sorts of stuff.
So I do want to say that in the short term, if you have bleeding or you have bad ulcers or you have to be on something because you need to be on it, you're on a medicine. My issue is not in the short term. My issue is I'm going to continue writing a script and you're going to be on it for the rest of your life. That needs to be discussed, because that's probably not one of the drugs you want to be doing. Or if you need to be on it, what's the lowest dose you can get away with? Can you use natural things to help to get on the lowest dose? I think the reason that this is happening is because the total lack of acid, I'm sure, is completely disrupting the normal microbiome, the gut flora. Because now, look, remember, the acid comes out into the small intestine and is neutralized by the bile. And then it goes and the bacteria get, exposed to this kind of neutral substance. Now you have all this bile without any acid. It's going to start to muck things around.
Well, half the job of the stomach acid is to kill. There's germs on our hands, as we all know. There's germs on surfaces. You eat something, it gets ingested. That acid kills some of those germs. That's part of that job.
We needed the acid. If not, we wouldn't have a vat of acid in our stomach. Yes. Again, if you need to be on it because you just had bleeding, you need to take the medicine. The medicine's awesome. I'm not having a problem with that. It's the people who are on it for 15 years.
Let me clarify that study. Was it just casual use of these, or were these people that were taking it?
No, they're taking every day.
That drug is you're only supposed to take it for no more than 2 weeks at a time.
No. A lot of people take it chronically all the time. Right. And if you were taking it once a day, your risk of contracting COVID was 2.2 times higher. And I don't mean relative risk, I mean 2.2 times higher. And if you were taking it twice a day, which some people take, it was 3 times higher. This is just a cautionary tale to be aware of.
So again, and I can't say this enough, that everybody's talking about where's the vaccine. We're going to talk about the vaccine in just one moment in the 4 minutes we have left. But if they're talking about masks, you're talking about social distancing. There's so many things you can do, again, like weight loss, like watch your, if you're taking PPIs, watch that, get your sleep, all these things that we can do to strengthen ourselves. That's our social responsibility as well.
Agreed.
To reduce the chance of contracting it.
Agreed. Just 2 things that I think are very interesting, which I've spoken about before. One is that there seems to be a link between, this was the New England Journal of Medicine, between your blood type and your risk of bad corona. And so it turns out if you're an A person, which might be good for high school, you are actually a 45% increased risk of bad corona.
Whereas the only A+ I ever got in my life.
Exactly. A+ you got was your blood type, and unfortunately it's not good for corona, and O was better. And then the other one, which was a fascinating study, I think, which was basically Proceedings of National Academy of Sciences, and that was looking at why Eastern Europe, you asked me who did well, Eastern Europe did much better than we did, and they have a theory that Eastern Europeans, most of Ukraine, get a BCG, which is a shot that they got to try and not get tuberculosis, which doesn't work, by the way. You can still get TB, but that might stimulate your immune system, and it's just a little bit better at reacting to viral things, because Ukraine had 10 times less deaths than Italy.
But we get TB vaccines here. It's just a different one.
Yeah. I don't know. I mean, the BCG is an old school one.
No, I know. So I'm saying it's funny that the TB vaccine that we get here is not effective, but there's something about this BCG.
Right.
Rarely used in the United States. Yeah.
Let's talk vaccinations.
Very briefly. Okay. So everybody's wishing, hoping, and praying. And then there's the crew that says, but it's not going to be safe because they're rushing it. And then AstraZeneca paused their test because of this one danger, adverse effect.
Yeah.
Which adverse effects have, that's the whole point of the testing.
That's exactly it. You go from 20 to 100 in phase 1 to a couple of hundred in phase 2 to thousands in phase 3. I want 30,000 people to be taking this before we do it, but when it's ready, and look, I've got to tell you that coronaviruses have been around, and vaccinations, because it's a type of cold virus, so have been around they've been doing research on this for 10, 15 years. Right. I think that we're going to find the vaccines will be relatively safe. I do. And if they are marginally, if they are effective, then that's great. I mean, I'm all over that because I think we're trying to hit the people with the biggest risk and trying to get some herd immunity. I mean, that's the whole concept here. I don't know. We won't know until we get the results. I do like the fact they're just trying to do it rather than the Russians who give it to 5 people and then say, "Oh, I've got a vaccine for you."
I mean, I am always, never want to be first online for those things because it takes a lot of testing and a lot of time. And sometimes it takes time in the mass population, even though they grow to larger groups of testers, that it takes time in mass population to find these pockets of adverse effects. So
I totally agree.
I'm always very conservative about it. And I think to AstraZeneca's credit, even though it's only one person at this moment in time, given the rapid timetable and the pressure to perform, it's far better for them to take their time and be careful.
There's no question. By the way, there's a Reuters article, and I saw this again talked about in one of the Connecticut journals, that they think about 25% of the population are not going to want to take a vaccination. So we'll have to see, I mean, and I don't know whether the whole world needs to be vaccinated. I don't know. I'm not a public health doctor. I know that high-risk people, this will be your moment.
Right. Got it. Real quickly, do I have about 30 seconds left?
Yeah.
The tests have been erratic. There were the NFL players that got tests and they were false positives.
Yeah.
So how confident can people be in the testing at this moment in time?
So I'm going to tell you one very, very, very interesting thing that just came out, and it's a nutmeg, so we should be proud of this. Yale University wrote a letter to the New England Journal of Medicine about their testing, which was actually quite accurate. In fact, potentially more accurate than the nasal swab, and it was using saliva.
Yes.
And what they did is they took, they did this on, so I also work in that system. And so they are testing the general, not the general public, but the employee population. And they tested 475 people. And then I can't remember the numbers exactly, but it's something like 13 of them tested positive according to the saliva. That eventually, when they did the next couple of nose tests, because in the beginning, if you do the nose test early, you miss the fun. Then it actually turned out that it was a little bit more accurate. So I'm very interested to see how the saliva thing goes, because having had a number of times this thing stuck in my nose so far that I thought my brain was going to be biopsied, I would much rather spit in the tube.
No kidding. Well, and again, that's testing for the presence of the virus, not necessarily that you have an active infection, but it at least means
that is right. That's true. But I mean, you're going to be doing that for people who have symptoms, and also as population, to see how much of the population has it or doesn't have it.
Right.
So Connecticut's doing well. We should be proud.
Connecticut's doing amazingly well. I have to say, truly.
Wear your masks. Wash your hands.
Pardon?
Wear your masks, wash your hands, don't lick people.
But if you're alone in the park, it's okay to not have your mask on.
That's all true. And if you want to lick yourself, that's your business.
Whatever you're into. Hey, any party shots. And again, let me remind everybody, if you have any questions, Joe and I rattled a lot of stuff off right here so that if you have questions, post them on in the chat. And he's very fast on his email to me. So, we'll get some answers out there for you. Any parting shots before I let you go? And thank you for your time.
Yeah, no, it's really a pleasure. I'm excited. I think we're going to win this. I really, 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 really do. It's going to be humanity 1, coronavirus 0. But we should also have respect for the fact that that nature's powerful.
Sometimes it just likes to challenge us.
Right.
What's your Facebook channel so people can see your
Facebook? So the easiest way is it's Dr. Joe Joe Feurstein. But I think that actually you should just go to drfeurstein.com. is my website, and that has all my videos.
Okay, watch Dr.
All righty.
Joe, thank you so much.
You're awesome.
All right, everybody. Next week I am back. We're going to be talking about what are we talking next week? Oh, patient advocacy with an amazing woman, Amy Dixon. So post your questions, post your comments, and come on back. Thanks so much. Thanks, Joe.
See you, Cesar. Bye.
Bye.